Afternoon. I'm Liz Goldstein, Executive Director of Anticoagulation Forum, and I'd like to welcome you to this special joint webinar being presented by the AC Forum and American Heart Association in honor of DVT Awareness Month. Today we will be discussing isolated distal DVT, selecting the best management strategies with expert speaker Dr. Natalie Evans. Dr. Evans is the medical director of the Non-Invasive Vascular Laboratory and a vascular medicine specialist at the Cleveland Clinic. She is involved with quality and safety initiatives for prevention of VTE at all Cleveland Clinic locations and is a national spokesperson for the AHA. We are thrilled to have her sharing her expertise with us today. Before we hear from Dr. Evans, we'd like to do a quick follow-up. Some of you may remember our last AC Forum AHA joint webinar focused on PAD-CAD and VTE prophylaxis in the medically ill. As a follow-up to that webinar, the AC Forum has published 2 new order sets for these indications. I'm very pleased that Diane Worth, AC Forum board member, will briefly describe how these order sets can help you improve patient care. As always, we'll be taking questions from the audience. Please type your question into the Q&A box. AC Forum board members Dr. Sarah Vasquez and Diane Worth will moderate your questions for Dr. Evans. Thank you again for joining us, and I'd like to now introduce Diane Worth.
Thanks, Liz, and welcome to our webinar. And as Liz said, we're going to share now some order sets that are hot off the press, specifically around CAD, PAD, and VTE prophylaxis for the medically ill patient. So, why do we need order sets? Well, I think as clinicians, we are very accustomed to clinical order sets now, and they definitely make our life easier. They standardize clinical decision processes, and you don't have to worry about what the proper dose is because someone has vetted that out for you and who the appropriate patients are. They are kept up to date, and they incorporate the latest evidence-based practice so that you're doing what's recommended for the patient. That has shown to improve their outcomes and reduce adverse events. And they're very easily integrated into the electronic medical records. So anyone now that's in the hospital should be on an electronic record, and these have been integrated. So the first one we're going to talk about is the VTE prophylaxis for hospitalized medically ill patients. And why has this come to light? Well, there's been a new paradigm shift after the APEX trial came out and the FDA approved extended prophylaxis for a certain subset of medically ill patients. And then we realized that we needed to take a step back and look and see what we were doing as organizations for prophylaxing the medically ill patient in the hospital, as well as are we doing adequate bleeding risk assessment. So hopefully this first order set will help explain what we need to do. And I want to point out that this is for the medically ill patient. This is not your surgical patient. This is centered around this order set, medically ill patients. So the first thing that we want to look at is what is their VTE risk assessment? And there's several tools available out there for us to use, and you can see they're listed here. The Improve, Padua, and the Caprini are the 3 most common that we see that we've included in our appendix here. And this first part of the order set shows you who's low and who's high based on what those scores are, and we're going to cover that. It's in the order set as well. But what I like about this order set is it also has the improved bleeding risk factor score that you can apply to those medically ill patients so that you can do an educated assessment of what the risk is for bleeding versus the risk of them having a venous thromboembolism. So what kinds of things do you have to gather before you decide? So there's important things that you want to look at. So there's lab functions that will help guide you with what the best pharmacologic agent, or if they're not a candidate for that. These are just your basic labs, and we've included the Cockroach-Gault equation there for those that don't want to download it on your phone on an app, but that will help estimate their creatinine clearance because we know a lot of these drugs are cleared renally. But then section X of the order set is pretty much the APEX criteria. So for those patients that are medically ill and you're contemplating using an oral agent, specifically Betrixaban, because it's the only one that's FDA approved, you want to make sure that you go down and look at each one of these boxes and make sure that the patients meet the criteria, that if you're going to place them on this, they have coverage, that they don't have a contraindication, and that they meet the criteria as you can see listed there. We're not going to go through all of those, but they're listed there on the order set to help guide you to see if this is an appropriate patient, because not every medically ill patient is a candidate for extended treatment. So what are your options? So you now have an oral agent, which is Batrixaban, and that's going to be based on what your results from Section X come out of. Or you could still use your parenteral, which is your list of your low molecular weight heparin, unfractionated heparin, or fondaparinux, depending on what their renal function is. And then you still always have mechanical prophylaxis. But the one thing that is evident when you do that risk assessment is those patients that are low risk may not need any of this, so that would stop you at the top of this order set. If you do decide to take and use the extended prophylaxis because the patient has met the criteria in Section X, you would then dose them accordingly. So you would load them with 160 milligrams that first day and then 80 milligrams for 35 to 42 days. If they have normal renal clearance, and then it would be half of that if they have lower renal clearance or if they're on one of those drugs. The other thing that this includes at the appendix there are the risk assessments for VTE, and you can see there the scoring there for both the Improve 7 and Improve 4, and then there's the Caprini there, which is much more complex, and then what the scoring system is down at the bottom. So these are the appendix, and then you can just pull that into your the front of your order set of what their risk is. We just thought it was a nice addition to the order set, so you don't have to go looking for them. Now we're going to move into the second order set, and that's based off of the COMPASS trial. And this was a study that looked to see whether rivaroxaban alone or in combination with low-dose aspirin would be more effective than aspirin alone for prevention of cardiovascular events. And it looked at safety as well as major bleeding, minor bleeding. And the outcome was that rivaroxaban was indicated in combination with aspirin to reduce the risk for major cardiovascular events, specifically cardiovascular death, myocardial infarction, and stroke, in those patients that met the criteria with chronic CAD or PAD. So safety initiation, what do you need to think about with these patients? So you want to make sure that the patients meet the eligibility criteria, that there are high-risk patients that they meet the criteria that's listed here, which is right out of the COMPASS trial, as well as for peripheral artery disease, and we're not going to go through each one, it's listed there. And then the use is not recommended in those patients that, you would not give it to someone with pathological bleeding or severe kidney disease, breastfeeding, mechanical heart valves, if they had another indication. And it's only for patients that do not require triple therapy. So they can be on aspirin and apixaban, but you don't want patients on triple therapy. They were not included in the study. And then there's cautions there as well. So what factors would influence the use of the DOAC in this? So you would want to make sure their renal function was adequate, and it was not recommended in patients with creatinine clearance of less than 15. And if they had a child QC or higher for hepatic function, it was a contraindication. And then you'd want to take and make sure that you address if they were significantly overweight or underweight, because they weren't studied widely in here. And then again, with concomitant use of certain medications, you would want to avoid the use. So initiation, what do you need to do? So you would use rivaroxaban 2.5 twice a day, not once a day, in conjunction with aspirin 81 milligrams here in the United States. And you want to make sure that if they're on another antiplatelet therapy, such as ticagrelor or clopidogrel, that it was safe for them to come off of that. And then there's baseline labs, and then communication with the patient of when they need to have those labs checked again. And then you want to take and consider, can the patient afford this, what their bleeding risk is, make sure you educate them about bleeding risks, as well as what follow-up appointments are necessary and follow-up labs, that they have a go-to point if they have any bleeding so they know who to call. You may want to consider enrolling these patients in your anticoagulation service so that they don't fall through the cracks, because they can still have bleeding when they're on the rivaroxaban 2.5 BID, just like they can with the other dosages. and then when they would seek medical attention, and make sure they have some information in writing per your health system policy for an oral anticoagulant. So with that said, that's just a brief overview of those 2 order sets that are now available on the AC Forum's website. I am going to turn this over, and I'm pleased to introduce Dr. Natalie Evans, and she's going to discuss today the isolated distal DVT and selecting the best management strategies. Dr. Evans?
All right, well, thank you so very much. I'm so excited to be here. Let me see if I can share my screen. And I really thank the Anticoagulation Forum and American Heart Association for inviting me to give this talk. So here are my disclosures. So today what I'd like to talk a little bit about is which isolated distal DVT we should be treating with anticoagulation. And if we're not anticoagulating these patients, how should we manage them? We'll talk about a little bit about which anticoagulant we should use and how long we should treat. And then finally, I'll just talk very briefly about patients with cancer and isolated distal DVT. And so I thought I'd present a couple cases just so we can start thinking about these things. So these were patients I've seen on my inpatient consultation service. The first is a 19-year-old woman who came to the emergency department with left knee and calf pain about 13 days after an ACL surgery. So she's someone who had multiple ACL reconstructions. In the emergency department, she's got normal vitals, her knee is healing, but she has left ankle and calf swelling. Her creatinine, hemoglobin, and platelets are all normal, and a venous duplex was done, and it shows thrombus in 2 calf veins, so the peroneal, and you can see here her gastroc veins with thrombus in them, these little barbell things. A second case is a 59-year-old man. He came in for lumbar spine surgery 3 days before, and now he's ready for hospital discharge. And he denies like symptoms. He's ambulatory, and his vitals are normal. There's nothing really remarkable on exam. He does have stage 3 CKD. His hemoglobin's a little low post-op, and his platelets are normal. And even though he was asymptomatic, a screening ultrasound was performed, and it shows a peroneal DVT at the mid-calf. So just think about those cases for a little bit. I think it's important when we talk about distal DVT that we make sure we're all on the same page. So what we're talking about is calf DVT in the posterior tibial or peroneal veins, and also the muscular veins of the calf, which are the soleal veins and the gastrocnemius veins. Anterior tibial vein thrombosis is pretty rare, and so most protocols don't even look at these veins. The calf muscle veins, we're not really sure what the significance of thrombosis in these veins is. Some people would argue that it's unimportant, but we tend to treat them the same as we do true deep vein as clots in the true deep veins. So why is this important? So we know that symptomatic proximal DVT typically begins around the valves in the veins of the calf, and without anticoagulation, some proportion of calf DVTs progress or extend to the proximal veins. Untreated proximal DVT can be really problematic because it can cause PE in up to half of cases, and PE is serious. So 10% of patients with PE may die within the first hour of their disease. We also know that post-thrombotic syndrome definitely occurs in proximal DVT. It's less clear with calf DVT, but we think it's possible. So calf DVT is clinically relevant. So why not just treat them all? As I tell my patients, taking anticoagulants is not like taking a multivitamin. So everyone has some associated risk of bleeding. And the case fatality rate of major bleeding is 2 to 3 times that of recurrent VTE. And VTE treatment trials don't account for individual variation in bleeding risk. Mark Carrier's group did a meta-analysis of symptomatic VTE on anticoagulation, and they showed that the case fatality rate of recurrent VTE after the first few months of treatment was 3.6% compared with a case fatality rate of major bleeding during the first 3 months of anticoagulation of 11.3%. Now, we may assume that the rate of major bleeding is lower after 3 months because a lot of those patients get selected out. But nevertheless, bleeding is a concern when we're anticoagulating patients. Isolated distal DVT is common, although we don't know how common because the studies that are done are very highly variable. And it depends on the population you look at as well. So among inpatients, isolated distal DVT counts for about 20% of diagnosed DVTs. But if you look at whole leg ultrasound of some outpatient studies, you may get up to half, 60%, 70% of these cases being isolated distal DVT. And of course, this is operator dependent, depending on your the skill of your sonographer and also some patient factors. When we think about how we're going to treat patients for distal DVT, we tend to think that if symptoms are more severe, we should be treating, and certainly if the extension risk is high, that we should be treating with anticoagulation. And who's at risk for thrombus propagation? So patients who have a positive D-dimer are more likely to propagate to proximal veins. Those who have extensive thrombosis or thrombosis in more than one calf vein are more likely to propagate. And then those with unprovoked DVT and active cancer are at higher risk for propagation. Patients with a history of prior VTE and those who are inpatients who are typically also at higher risk for bleeding have higher rates of thrombus propagation. I included this study. It's old and it's small and it's methodologically flawed, but this for a long time was the basis of treatment, the treatment recommendation for isolated distal DVT. So it was a very small study in 1985 of 51 patients who were randomized either to unfractionated heparin overlapping with warfarin and treated for 3 months versus initial heparin with no further treatment. And what these authors found was that patients who were not treated had a very high risk of recurrence over a year's period. So about 2/3 of them in the no warfarin group had recurrent VTE. And so just based on this small study, for many years, the ACCP recommended anticoagulation for calf DVT. And I would love to tell you that since then, a whole bunch of randomized controlled trials of anticoagulation of isolated distal DVT have been performed, but in fact, that's not the case. There's very little data out there on how to deal with calf DVT. So another group did the ACT trial more recently, but it was only a feasibility study. So it looked at 70 patients who were randomized to 3 months of anticoagulation versus no anticoagulation at all. And they all had a repeat ultrasound at 7 days to look for proximal propagation because obviously those patients would need to be treated. And the primary outcome here was a composite of proximal propagation, PE, VTE death, and major bleeding. And they found that 11.4% of the patients who were not treated had one of these outcomes, and none of those outcomes were bleeding, compared with 0% of the treatment group. But because this study was small and a feasibility study, there was no statistically significant difference. The CalThro trial was more of a natural history study. So it looked at patients who were had either a high clinical pretest probability or a positive D-dimer, but who had a negative proximal leg ultrasound only. So the calf veins were not examined. All of these patients got whole leg ultrasound at enrollment. And then the study authors were blinded to this until a patient either had an outcome or the study was completed. So they all got repeat proximal ultrasound at 5 to 7 days. And if they had propagation, then they were started on anticoagulation and they were taken out of the study. If there was no propagation, then they were merely observed going forward. And so the group who had isolated distal DVT, most of them, or a third of them, had involvement of more than one vein. So they would have what you could consider extensive distal DVT. 2 of those 65 had extension and ended up being anticoagulated, and 5 events were detected at 3 months, including those 2. But if you exclude the events detected at 5 to 7 days, then the difference is barely statistically significant. And so it's about 4 or 5% of patients who are just observed eventually have events, but you're weeding out the people who had proximal propagation with an ultrasound at 5 to 7 days. The CACTUS trial looked at a shorter duration of anticoagulation. So patients with symptomatic CAF DVT, excluding those with cancer or a previous venous thromboembolism, were randomized to a low molecular weight heparin versus placebo for 6 weeks. All of these patients got compression stockings. And the primary efficacy outcome here was a composite of proximal DVT or contralateral DVT or symptomatic PE at 6 weeks, with a primary safety outcome of both major or clinically relevant non-major bleeding at 6 weeks. And so this group found that there were about 3% of patients in the treatment group who had VTE at 6 weeks, and about 5% with VTE at 6 weeks in the placebo group, but this was statistically not significantly different. However, about 4% of the patients in the treatment group had bleeding, so major or non-major clinically relevant bleeding at 6 weeks, compared with nobody in the treatment group, and this was significantly different. And so the authors felt like this might justify not anticoagulating patients with isolated distal DVT. Now, this study was small and they struggled with enrollment, so they met only about half the pre-specified sample size. The authors of the CALTHRO trial pooled together their data with the CACTUS trial, and they showed that the VTE rate of untreated isolated distal DVT at 3 months was about 10%, which they argued is really not negligible. And so maybe these patients do warrant treatment, and perhaps we can use D-dimer and pretest probability to help us determine who's at low risk for extension and who may not be treated. So that's a summary of most of the work that's been on treatment of isolated distal DVT. One of the questions is, so we think that we should be treating patients who are more symptomatic, so does anticoagulation reduce pain? And so the CACTUS trial authors looked at this as well. Their patients all were asked to rate their leg pain using a visual analog scale, and they found that there was no difference at 1 week or at 6 weeks comparing the treatment arm versus the placebo arm. But again, this is the same small study and it's a post hoc analysis, so it's hard to draw really strong conclusions from this. So if we're gonna anticoagulate our patient, what anticoagulants should we choose? And the answer is we don't know because it's not been studied. The current guidelines for DVT and PE suggest a direct oral anticoagulants over vitamin K antagonist in patients who don't have cancer. And in those who have cancer, they suggest a low molecular weight heparin over a VKA or a DOAC. But as we start to accumulate evidence for the efficacy of the DOACs in cancer patients, this is really open to question. So it certainly is unknown what the optimal agent is, but it seems reasonable to treat these CAF DVT patients with a DOAC. And of course, as far as intensity of anticoagulation goes, we don't know that either. And so this is an area that really needs further research. When we think about how long to treat, I just want to call your attention to treatment duration, a shorter treatment duration versus 3-month treatment duration. And so this is the time after stopping treatment. And these are patients with isolated distal DVT. And so you can see that there are higher rates of recurrent VTE for all of these lengths of time in patients who are treated for just 1 or 1.5 months compared with patients who are treated for 3 months. So 3 months may continue to be the optimal duration of treatment for isolated distal DVT. And the guidelines recommend 3 months compared with longer, and that gets a reasonably strong recommendation. And then they suggest 3 months compared with a shorter regimen, which is a weaker recommendation. Just a word on bleeding risk. So when we're thinking about anticoagulating calf DVT, the DOACs appear to be pretty safe. And so in the randomized controlled trials that got all of these drugs approved, DOACs were associated with lower rates of major bleeding, fatal bleeding, clinically relevant non-major bleeding, and total bleeding compared with VKAs. And in the trials, at least, there was no increased risk of major GI bleeding as well. And the real world data suggests that the observed bleeding rate is probably lower than experienced with warfarin. And so when we're treating calf DVT, maybe the DOACs are a better option. DOACs versus, there was a meta-analysis that looked at this that showed low fatal bleeding rates compared with VKAs and a lower case fatality rate. This retrospective matched cohort of patients showed a 3.3% major bleeding rate in the first 90 days for the DOACs, 1.7% all-cause mortality, and the bleeding rate was at least similar to warfarin, but not higher than warfarin. So when we're thinking about who we're not going to anticoagulate, I think bleeding is probably the biggest consideration. And so you can see here some predictors for bleeding in patients from the READY registry. And patients who have recent major bleeding, elevated creatinine, anemia, cancer. Interestingly, patients who have PE and older patients are more likely to bleed, and you can plug numbers in and find that patients who have a score greater than 4 had a 7.3% rate of major bleeding over 3 months. So if we have a patient who has a lot of these risk factors, then we may say, well, I don't want to anticoagulate these patients. So what do I do? Well, it's not an option to do nothing. If we're not going to anticoagulate, then we need to perform serial ultrasound. And when and how often to perform are actually unknown. But the CHEST guidelines would suggest 5 to 7 days after the initial diagnosis of calf DVT and 5 to 7 days again after that if there's no propagation. If there's propagation to the proximal veins, then your patient needs anticoagulation. And if your patient can't be anticoagulated because of bleeding, severe thrombocytopenia, or so on, then they need a temporary vena cava filter. If there's propagation below the knee, anticoagulation is typically recommended, but in my experience, when I've had patients who are very high bleeding risk, I've continued to pursue a serial ultrasound strategy, and then only if they propagate above the calf would I put in a filter or try to figure out what my anticoagulation options are. I see, there we go. Okay, so what about cancer? So this is really another evidence-free zone. So we don't know how to manage cancer patients with isolated distal DVT, either with respect to duration of anticoagulation or choice of anticoagulant agent. It's hard to think about committing someone to indefinite anticoagulation for just a calf DVT, though, because there's so little we know about it. This group looked at residual vein obstruction in patients with cancer. So RVO has been looked at as a risk factor for recurrent VTE, and it's not really used much because it's not clear. But at least in the case of these patients with cancer, those who had residual vein obstruction had double the recurrence rate after anticoagulation was stopped. So if you're thinking about what you're going to do with your cancer patient with an isolated distal DVT, looking at what they have on a repeat ultrasound may be helpful. Although this was a very small study, it was a post-hoc analysis and patients were treated for variable length of time. So it's tough to draw conclusions. So finally, I want to get back to our cases. So our first case was a young lady who had had ACL surgery. She, at the time, was immobilized and she had thrombus in 2 sets of veins and she was symptomatic. So we would consider her to have risk factors for propagation. She'd had a recent surgery, but it was was almost 2 weeks ago, and she was otherwise low risk for bleeding, and her orthopedic surgeon was okay with it, so we felt like we would just go ahead and start her on anticoagulation and discharge her directly from the emergency department. In our second case, this patient we felt was low risk for propagation. So he was totally asymptomatic. He had a reversible risk factor, which was his surgery, and now he was ambulatory and going home. And he had thrombus isolated to one vein. He also had this recent surgery that put him at risk for bleeding as well as chronic kidney disease. And he lives close to the medical center, so he was able to come back for repeat ultrasound. So that was the strategy we pursued with that patient. So in summary, isolated distal DVT is common, but the prevalence varies by population, and it's the sparse data about how to treat isolated distal DVT make the optimal management still unclear. We typically anticoagulate patients who are symptomatic, who have extensive isolated distal DVT, or who have risk factors for propagation, but more research is needed into the optimal intensity and duration of anticoagulation. And with that, I thank everyone for their attention. And that's, those are the end of my slides.
Thanks, Dr. Evans, and I will go ahead and ask the first question. Can you comment on, I'll start my video. Can you comment on the difference? Some centers actually don't perform whole leg ultrasound, and they only perform proximal ultrasound. So can you comment on the difference in strategy and what your recommendation is and what you guys do?
Yeah, so at the Cleveland Clinic, our lab is accredited by the Intersocietal, the IAC, and their protocol recommends whole leg ultrasound. So we do whole leg ultrasounds on everyone. I'm not 100% familiar with the ACR, the American College of Radiology, criteria, but I think that they also do whole leg ultrasound, and whole leg ultrasound in the United States is pretty common. And so, you know, obviously you're not going to catch calf DVTs with a proximal ultrasound only. I kind of like the idea of it, because if you do a proximal ultrasound and there's no thrombus, you bring them back in 5 to 7 days, and if they haven't propagated, you do nothing. And there's a very low rate of VTE in that group. And so it takes out this whole decision tree about what do I do with this calf DVT. But the problem there is getting people back for repeat ultrasound is labor intensive. It can be costly, and so it can be problematic. I know in Canada and other places, proximal ultrasound is the strategy they use.
Okay. Thank you.
Sure.
Great. There's a couple of questions now about surrounding the D-dimers, and I know they're non-specific, and in a setting where there's surgery, you may have an elevation of the D-dimer from that, correct? So at what point do you consider it elevated, and what settings, and should we be measuring them on all patients that have distal DVTs?
So I think, the place you're going to use D-dimer is in your outpatient population. And so I really think there's no utility to using a D-dimer in the hospital unless you're using it like for the APEX trial to determine who you're going to put on prophylaxis, because for absolutely that reason. So people have in the hospital, you know, it's kind of like you walk in the door and you have an elevated D-dimer. So I don't think it's particularly useful in deciding who we're going to scan on the inpatient side.
Okay, thank you.
Dr. Evans, there's a question about bleeding risk and thrombocytopenia. What is your threshold for either withholding anticoagulation in the setting of thrombocytopenia or proceeding?
Yeah, so I had a med school professor who said, as my son, the lawyer, says, it depends. So I think it really depends on so first it depends on the DVT. So for a calf DVT, I might have a much higher threshold for thrombocytopenia. We are pretty gutsy at times at the Cleveland Clinic, and we will anticoagulate people with really low platelets. My general level of comfort is 35,000. If I'm not really excited about anticoagulating the patient for some other indication like portal vein thrombosis or something where it's not as clear cut, and you could argue that calf DVT would fall in that category, then I might say 50,000. I typically above 50,000 will anticoagulate, even, full therapeutic anticoagulate patients who need it.
But your point is you'd have a potentially higher threshold for distal DVT.
Yeah, absolutely. Absolutely.
Good, thank you.
Sure.
So I know we talked about the lower extremity distal DVTs. Well, what about the upper extremity distal DVTs, and how do you treat those, and what should we be doing with those patients?
Yeah, it's such a great question because we see so many of them. And I don't know if this is the case at other medical centers, but I feel like we look for them too often. And I also feel like you walk in the door of the hospital and your D-dimer goes up and you get a PICC line. And so we're seeing so many more upper extremity DVTs that are catheter related. My approach, so the guidelines would suggest treating axillary and above, so axillary, subclavian, IJ, and innominate DVT. And so I tend to treat those patients for 3 months with anticoagulation if they can be treated. We do something similar to calf DVT in patients who can't be anticoagulated, which is we do repeat ultrasound at 5 to 7 days. And it's highly variable depending on who's on the service, what that interval is, but I do 5 to 7 days. And if they propagate more proximally, then my hope is that by 5 to 7 days, they're safer for anticoagulation. And then there's the question of what do you do with the catheter? And so for patients who have upper extremity DVT and the catheter is functional, we don't take it out, we continue to use it regardless of whether we're treating the patient or not. Because if we take it out, oftentimes they need another one somewhere else and they have another nidus for thrombus formation.
Great, thank you.
So is there ever a situation, Dr. Evans, where you would extend serial ultrasound monitoring beyond the first 2 weeks?
Yeah, I think so. I mentioned the patients who, if they extend below the knee. So for instance, if you've got a peroneal vein thrombus and I decide not to anticoagulate you and I get a serial ultrasound at 7 days and now you've got a posterior tibial thrombus, then I might extend that for an additional 2 weeks. And that would be in someone where I'm absolutely not going to anticoagulate them. I think if you get to the point where they're just extending into every set of calf veins and the patient can be anticoagulated, then it makes sense to anticoagulate them.
Okay, thank you.
Let's piggyback off that one, and maybe it's not just the isolated. Do you ever do repeat ultrasounds before you stop therapy to determine what the residual clot is or if it's safe to stop?
Yeah, so that's such a great question. And my old answer was, so the American Board of Internal, American Board of Internal Medicine and the Society for Vascular Medicine I don't know if you all remember the Choosing Wisely campaign, but repeat ultrasound was something they recommended against. And so the Choosing Wisely campaign was directed at patients. So, if your doctor tells you you need a repeat ultrasound, you should question it. Because it doesn't determine my treatment duration. So a patient who has a DVT that's provoked by a reversible risk factor, I'm pretty much never going to treat them longer than 3 months. And so I typically don't in the olden days at least, I didn't look again. I started using ultrasound to see what the residual, it's not thrombus anymore, it's chronic post-thrombotic change. By 3 months, whatever's there has turned into a scar. And so if I'm going to stop anticoagulation, a lot of times I get an ultrasound so that I know what that patient's new baseline is, because we end up with a problem of patient comes back to the hospital with new leg symptoms. You get a scan, you see all this old thrombus, and sometimes it gets called as new thrombus, and maybe it's not really. And so having that baseline ultrasound is super helpful.
Great, thank you.
Unmute myself. Let's ask a question about what happens in the patient that you are, let's say, choosing to do serial ultrasounds on. Is there a role for treatment, symptomatic treatment in that 1 week? Do you prescribe compression stockings or anything like that?
Oh yeah, sure. So compression stockings are great, and I used to prescribe them to prevent post-thrombotic syndrome, and that has become questionable with the results of the SOX trial. But I think symptomatic treatment with some kind of compression, having the patient elevate their legs, is very helpful. I think one of the questions that I have, and is, should we be treating, so if we're gonna do serial ultrasound, should we be putting patients on prophylaxis intensity anticoagulation if they can take it? And a lot of times we do, especially if they're going to a skilled facility or acute inpatient rehab where, you know, it's easy to get an injection. But I don't know that, I mean, nobody knows the answer. There's no data to tell us what the right thing to do is. Sarah, I don't know if I answered your original question though. Did I answer your original question?
Well, about compression, yes. Are there other things in addition to compression that you recommend for symptomatic treatment in that interim period?
Oh, like NSAIDs or something like that? Yeah, not really.
Yeah, okay.
So let's go back to that hospitalized patient, and they're in the hospital and they have been receiving VTE prophylaxis, and they still develop a lower extremity or calf DVT. Does that change your approach or not?
So, I don't know how to answer that question because it's really hard. So if someone has a calf DVT, despite getting, you know, they got all the doses of prophylaxis that they were supposed to get, it makes you worry that they're at high risk for, you know, that they have a lot of thrombotic potential. And so would that make me more likely to anticoagulate them fully? It might, depending on the clinical scenario. A lot of times when they're inpatients, you know, it's like the same things that put you at risk for thrombosis put you at risk for bleeding. And so a lot of these patients, it feels like they're at higher bleeding risk. They're elderly, they have chronic kidney disease, they have a history of bleeding. And so you worry about, I worry about anticoagulating patients. Nothing keeps me awake at night like worrying about somebody having bleeding.
Great, thank you.
Dr. Evans, can you clarify, go back and clarify about distal DVT in the cancer patient and clarify the risk that cancer presents versus the risk for bleeding and how you balance that?
The short answer is no, because I don't know the answer. But yeah, so patients with cancer are at high risk for, so they're at high risk for incident VTE, and then they're at high risk for recurrent VTE. And they also tend to be at risk for bleeding, just some underlying badness about cancer plus things, you know, site-specific things. And so I think it really, when you're anticoagulating somebody with cancer, I think it can be really helpful to talk to so as a vascular medicine person, I am not trained as an oncologist. It really helps me to talk with the oncologist, to talk with the patient about risks and benefits, and to do shared decision making. And I think, I mean, with all venous thromboembolism, shared decision making cannot be underestimated. But it's particularly important in these patients. You also, you know, the cancer chemotherapy, a lot of patients are at risk for thrombocytopenia, and actually talking to pharmacy is super helpful for getting a sense, because I don't know, you know, what chemo drugs necessarily cause thrombocytopenia and which ones it's an unexpected side effect. And so talking to all those parties can be helpful in decision making.
That's a good point. Good communication. Thank you.
Yeah, I mean, it's essential. I think it's essential for all of our VTE patients, but in particular patients with cancer.
Could you do a little anatomy and physiology and tell us at what point do you worry that it's getting too close to the proximal vein? I mean, if it's just below it, when do you worry more and are more inclined as opposed to not?
Yeah, so nobody knows the answer to that either. And our sonographers in the vascular lab here at Cleveland Clinic are usually fantastic about if it's close to the junction with a popliteal vein, they'll give us a measurement. It depends. So if I have someone who's low risk for anticoagulation and they have a calf DVT that's within a few centimeters of the popliteal vein, then I'm definitely going to anticoagulate them. I probably would have anticoagulated them anyway because they're low bleeding risk. But again, nobody knows the answer to that question. I think we tend to use 5 centimeters here.
Okay.
Yeah. Which is not, it's not, you know, that's not very far.
So Dr. Evans, a question is to put on your wish list, if you were to be able to design a trial to better assess anticoagulation for distal DVT, what would your study arms be?
Yeah, so I think I would love to see, so I think the question, it's still an open question whether we should anticoagulate. So some of these patients probably don't need to be anticoagulated at all. Yikes, this is a hard question. I think honestly, I would look at duration of anticoagulation. So I would start with, I would love to see a large randomized controlled trial of isolated distal DVT comparing 3 months versus 6 weeks to see if reducing the time frame changes outcomes. So that'd be the first one. But I also think we need treatment trials of no anticoagulation, and that is, I think, really, you know, you would have to put in that repeat ultrasound into the equation because you'd have to catch propagation in the first 2 weeks. I don't think I talked about, so there's some very limited data that by the end of 2 weeks, if they haven't propagated, then they shouldn't propagate. And so that's why we use that cutoff. And so if you did any kind of randomized controlled trial of no anticoagulation, you'd have to build that safety aspect into it with a repeat ultrasound.
So,
great. Thank you so much. I'd like to thank all of our expert speakers today, Natalie Evans, Diane Worth, and Sarah Vasquez. Thank you very much for this rich discussion and great panel. If you missed any of this presentation today, the webinar has been recorded and will be posted on the AC Forum and AHA websites by early next week. Just a quick reminder to register for our national conference, which is coming up in a few weeks in Fort Lauderdale, Florida. And lastly, I'd like to thank our corporate sponsors who help support this webinar program. Thank you again for joining us and have a nice day. Thank you.